I'm Dr. Nathaniel Chin, and you're listening to Dementia Matters, a podcast about Alzheimer's disease. Dementia Matters is a production of the Wisconsin Alzheimer's Disease Research Center. Our goal is to educate listeners on the latest news in Alzheimer's disease research and caregiver strategies. Thanks for joining us. Welcome back to Dementia Matters. Today I'm joined by Dr. Reisa Sperling, a neurologist focused on detecting and treating Alzheimer's disease at the earliest possible stage. Dr. Sperling is a leader in the field of Alzheimer's research and holds numerous titles and roles, including serving as a professor of neurology at Harvard Medical School, the director of the Center for Alzheimer's Research and Treatment at Brigham and Women's Hospital and Massachusetts General Hospital, co-principal investigator of the NIH-funded Harvard Aging Brain Study, and one of the principal investigators of the Alzheimer's Clinical Trial Consortium. As part of her work in clinical trials, she has co-led the anti-amyloid treatment in asymptomatic Alzheimer's disease study, also known as the A4 study, the first prevention trial in late-onset preclinical Alzheimer's, and is currently co-leading the AHEAD study, a trial testing whether lecanemab could lower a person's risk of memory loss due to Alzheimer's. Dr. Reisa Sperling, it's my honor to have you on Dementia Matters. Thank you for being here.
Thank you so much for having me, Dr. Chen.
And so there's a lot to discuss here, and we will likely be breaking this down into 2 episodes so that we can cover it and give enough coverage to all of these important topics. But for this beginning, I'm hoping you can explain for our listeners what exactly preclinical Alzheimer's disease means and how you see it being incorporated into both the research and clinical staging of Alzheimer's.
Well, thank you very much for having me. I'll say that I think of preclinical Alzheimer's disease as people who have the brain changes related to Alzheimer's disease that are detectable before there are symptoms. And people often ask, why didn't we just call it pre-symptomatic Alzheimer's disease? But of course, the harder we look, the more we can see evidence of very, very subtle changes, but people are not clinically impaired. It is before the stage of mild cognitive impairment or dementia, and so it's known as preclinical Alzheimer's disease.
And so you are truly separating biology from then impairment, not really symptoms, because you could have symptoms across the whole spectrum, but true impairment.
So I believe that Alzheimer's disease is best defined by the underlying biology, these changes that happen in the brain, namely the buildup of amyloid plaques and tau tangles. And people can have a variety or a continuum of clinical manifestations of Alzheimer's disease as the underlying pathology. And it begins with a long asymptomatic or preclinical phase of Alzheimer's disease. And then we can see that there's kind of this transitional phase where people start to have very subtle symptoms or decline and then progress to the stage of mild cognitive impairment.
When did the term preclinical Alzheimer's become prominent in Alzheimer's research? And then how has its understanding evolved, particularly because of studies like Diane and now in individuals with ApoE44?
So the idea of preclinical Alzheimer's disease, I think, had a lot of prominence starting in about 2011 when the National Institute on Aging and the Alzheimer's Association put together a work group to look at the continuum of Alzheimer's disease. And there were multiple studies that had started and were beginning to publish at that time. Beginning with, you mentioned Diane, the Dominantly Inherited Alzheimer Network. And these are individuals who, of course, have a very rare mutation. It's a deterministic mutation, though. So people who carry that mutation will develop a dementia due to Alzheimer's disease. And some of that early work, as well as work from ApoE4, homozygotes, and other genetic risk, including trisomy 21, showed us that the pathology of Alzheimer's disease, these changes in the brain, begin well more than a decade before people get to the stage of clinical impairment. Around this same time, though, back in the early 2000s, amyloid PET imaging became available. And many groups, including ours, started doing studies with PET imaging, and we recruited what we call normal controls. And those normal controls who did pretty well on testing reported they didn't have problems. About 30% of them over age 65 also showed evidence of amyloid abnormalities on PET imaging. And at first, everyone said, well, amyloid must have nothing to do with Alzheimer's disease. If you can see the amyloid building up on these PET scans and these people are still, quote, normal, end quote. Well, over the next few years, we followed those individuals who had amyloid PET abnormalities. There were also studies with spinal fluid. And unfortunately, we could see that those who had elevated amyloid, even though they started out normal, had an increased risk of decline, accelerated memory loss. And in fact, the timing between the amyloid PET buildup was very similar in late onset preclinical Alzheimer's disease to what had been reported with dominantly inherited Alzheimer's disease and other genetic risk.
And then how does the ApoE44 gene come into play?
So, ApoE4 is the most common genetic risk factor for what we call late onset Alzheimer's disease. And about 25 or 30% of people carry one ApoE4 allele. Only about 4% of the population carries two copies, meaning they inherited one ApoE allele from their mom and one from their dad. But that ApoE4 homozygotes actually make up 10 to 12% of people who have dementia due to Alzheimer's disease. And just last year, a number of us published a paper looking at ApoE44 homozygotes and showed that about 3/4 of those individuals had amyloid buildup by the time they were 65, and more than 3/4 developed dementia before they were age 75. So, very similar to the dominantly inherited story, although I'll say that ApoE44 homozygotes, it's not quite the same deterministic gene, but it is a group who is extremely likely to develop the biology and then the symptoms of Alzheimer's disease.
Well, why is amyloid not sufficient on its own to drive cognitive decline in preclinical Alzheimer's disease? And how does its interaction with tau influence disease progression?
I think that's an excellent question. So, what we do know is that there are people who have a fair amount of amyloid in their brains without a lot of tau, and they seem not to show much decline. I think we don't fully know whether if you had enough amyloid, a lot of amyloid, even without tau, whether you would still be normal. And I think some data suggest that if you have a lot of amyloid, you unfortunately still are at risk for decline, but not nearly at the stage of if you also have tau. And the reason is that most people who have a lot of amyloid in their brain also have increased tau. I think we don't yet know whether amyloid actually drives tau, or I would say I've come to think the data support the idea that the same process that allows people to accumulate amyloid also enhances their likelihood of accumulating tau. Meaning, as we get older, we can't clear these proteins nearly as well from our brain. And even though amyloid is outside of cells, primarily in plaques, and tau is mostly inside neurons, I think it's the same failure of clearance mechanisms that are problematic in both. And that is why I actually think that even when you go after an anti amyloid therapy, you can augment or slow tau from depositing, because I think you're helping the brain be able to clear these proteins through natural mechanisms, and that we can at least influence tau with lowering amyloid. And the last thing I'll say on this is that I think there may be other processes that interact with amyloid to hasten tau, and vascular disease being a big one that we and others have seen evidence for. Now, whether it does it through changing clearance mechanisms or there's something else about vascular disease that augments tau, we don't know. And there are also differences by gender, sex, that so women, for a given amount of amyloid, have more tau. So clearly, the relationship between amyloid and tau can be modulated by other factors. And of course, that's something we hope in the future to exploit and decrease tau.
Now, I've heard you speak at other conferences and presentations, and you do say that amyloid agitates or irritates tau. And I know that that's obviously just a way for the rest of us to be able to understand that there's a relationship. But do you believe there's something about amyloid that is interacting that converts tau, which is a normal protein inside the brain cell, to then become modified and then abnormal?
I think that I often say that there's evidence that the amyloid is bothering the tau. And the reason I say that in particular is that the phosphorylation step of tau, this what we measure in blood, what we call phosphorylated tau, there is evidence that that happens first at the edge of plaques, where there are what we call neurites, these extensions of the nerve cells, that the tau seems, when it's next to the amyloid plaques, seems to particularly starts this process of phosphorylation. I will say that we do not yet know whether that is what leads to tangles. We know that there's more what we call hyperphosphorylated tau in these tangles, but I think that whole process we don't know. But I am fairly confident that amyloid plays a role in the changes in tau. We never, or I would say very rarely, see tau spreading throughout the brain in an Alzheimer's like pattern without amyloid. You just don't see it. On the other hand, tau can cause other diseases like frontal temporal dementia when there's not amyloid there. So, what it is, the relationship between amyloid and tau that causes an Alzheimer's like tauopathy, if you figure that out, that's definitely Nobel Prize winning stuff.
Well, I'm glad you mentioned the word p-tau because my next question is, how do baseline amyloid levels in biomarkers such as plasma p-tau predict future cognitive decline and the transition to mild cognitive impairment or eventually to dementia?
So phospho-tau 217 is in blood, but it's a really good marker of how much amyloid plaque there is. And again, this is where the idea that phospho-tau is not just a marker of amyloid alone, but potentially that amyloid is bothering the tau or at least involved in this early process. And one of the best pieces of evidence on this for me actually came from the A4 study, the anti amyloid treatment in Alzheimer's disease study, where unfortunately we failed to be able to slow cognitive decline. And we didn't have blood based biomarkers at the beginning of the A4 study. But by the time we finished the study, there were very good markers available, and we could go back and look at the baseline levels. So, higher levels of amyloid PET are predictive of who will decline. And it's really that top third of individuals who progressed all the way to mild cognitive impairment. But interestingly, the phospho-tau, what we call p-tau 217 in blood, actually had a better prediction of who would decline than even the amyloid PET did. And over the past year, it's been really exciting to see multiple different studies have the exact same finding that phospho-tau in blood at a high level is very predictive of who will progress to mild cognitive impairment. And even now, some studies all the way to dementia, because they went back and looked at blood tests 10 years ago, including some of the work coming out of Wisconsin.
And Risa, you've taught me that a well done clinical trial is never a failed study. It might be disappointing to participants and families who obviously hope for the best, but this is a good example of we are learning from the data you collected in a good study as to exactly is happening in the pathology and the progression, and how meaningful that is when we have good data and being able to go back and ask new research questions.
Absolutely.
I suppose you're asking a lot more questions of A4 data too, since it is a treasure trove of data.
We are, and fortunately, it's now publicly available for people to use the de identified data. So we hope that researchers all over the world will be able to ask questions of these data because that's what our participants want us to do, which is to learn and try to. Design even better trials in the future so that one day we will succeed. and prevent Alzheimer's dementia.
Why is substantial amyloid removal necessary, even at the preclinical stage of Alzheimer's disease? And how does this inform treatment strategies going forward?
I think that the data from all of the clinical trials, those that succeeded in slowing cognitive decline and those that didn't, really converge on that evidence that you really have to substantially lower amyloid below baseline levels and probably into the amyloid negative range, meaning somewhere below 25 centiloids, to really slow cognitive decline. And what we saw in the A4 study was that people who had more than 46 xenoloids, or kind of, again, the top two thirds, were at increased risk of decline. And the group who stayed below 40 or so centiloids didn't show decline, as well as the LEARN group. This was a natural history study for people who did not have elevated amyloid in the A4 study. So all of that data really suggests that you need to get or keep amyloid levels below about 40 centiloids to really protect people against cognitive decline. And not by accident, it's about 40 centiloids of amyloid where you start to see tau spreading out from these deep parts in the brain, we call the medial temporal lobe, out into the cortex, which often, unfortunately, heralds cognitive decline. So I think there is some threshold of amyloid that you need to either stay below or rapidly decrease below to really protect against tau, which I think is more closely related to memory and cognitive decline.
And for our listeners who are not scientists and clinicians, how would you define centiloid?
Yes, and it's better to probably just think that centiloid, not surprisingly called centi, is a scale that was developed that goes from about 0 to 100, even though you can have negative numbers and levels above 100. But it was developed to be able to go across different amyloid PET, what we call tracers, the dye that you use in the brain to say how much plaque is there. And that centiloid scale was actually super helpful for being able to look across different tracers against different studies, different ways of processing to say, okay, do you have low amyloid, medium amyloid, high, or very high amyloid? And I would say that without using necessarily a centiloid scale, the evidence is that if you can keep people in that bottom third of amyloid, they generally don't show a lot of clinical decline, and they generally don't have a lot of tau spreading, although there's some buildup in those deep areas of the brain that we call the medial temporal lobe. But that's what we want to do, is keep people at the low end, because once they're getting to the medium or high levels of amyloid and then tau, they really are at risk for decline.
All right, so my last question for this aspect of our conversation is that there's tension in the field right now regarding the definition of Alzheimer's disease. And I don't want to spend a lot of time on this, but I do want to know, how do you respond to some of the critiques that amyloid is sufficient to define Alzheimer's disease?
Although I think, as I mentioned, that amyloid plus tau is what is likely associated with the highest risk of decline, there are two reasons that we in the Alzheimer's Association work group felt that it was important to define amyloid as the earliest stage of Alzheimer's disease. One, because we can see the amyloid building up before the tau, and the vast majority of people who have very high levels of amyloid have tau. In the autopsy studies that have been done by all the Alzheimer's centers around the country, it's 98% of people who have a lot of amyloid, meaning moderate to severe, what's called amyloid plaques, have tau. They have tau that's in the medial temporal lobe, and then the more amyloid you have, the more likely it is to be out in the brain. And then the second reason we felt that it was important to say that amyloid is the first stage and that it is sufficient to define Alzheimer's disease was that is what we use in the clinic to decide whether someone right now should be treated with an anti-amyloid therapy. If we require tau PET on everybody, that means we're not going to get it to the vast majority of people who need it, And we have plasma measures now, these blood tests that, again, even though it's a marker of amyloid, it has tau in the name. It's phospho-tau because, again, these proteins are related. And so it seemed important just to be able to make this simple and say that amyloid is a good marker of amyloid is sufficient to define Alzheimer's disease. But knowing about the tau is good for prognosis. It can help you decide how likely someone is to progress over what time frame. So tau is a good marker, but you don't need tau PET to be able to make treatment decisions for Alzheimer's patients.
Okay, with that, thank you, Reisa, for this first part of our conversation. And then to our listeners, tune in for part two. Thank you for listening to Dementia Matters. Follow us on Apple Podcasts, Spotify, or wherever you listen. Or tell your smart speaker to play the Dementia Matters podcast. Please rate us on your favorite podcast app. It helps other people find our show and lets us know how we're doing. If you enjoy our show and want to support our work, consider making a gift to the Dementia Matters Fund through the UW Initiative to End Alzheimer's. All donations go toward outreach and production. Donate at the link in the description. Dementia Matters is brought to you by the Wisconsin Alzheimer's Disease Research Center at the University of Wisconsin-Madison. It receives funding from private, university, state, and national sources, including a grant from the National Institutes on Aging for Alzheimer's Disease Research. This episode of Dementia Matters was produced by Amy Lambright Murphy and Kaylin Rowerdink and edited by Alexia Spevacek. Our musical jingle is Cases to Rest by Blue Dot Sessions. To learn more about the Wisconsin Alzheimer's Disease Research Center, check out our website at adrc.wisc.edu. That's adrc.wisc.edu. And follow us on Facebook and Twitter. If you have any questions or comments, email us at dementiamatters@medicine.wisc.edu. Thanks for listening.